Let's move on to our sixth table. Last but certainly not least, you have the complex task of how do we improve care for older people.
Thank you. As you'd expect, being a sixth group, there's some overlap with some of the other tables, but I think we've got a couple of nuggets that are fairly stronger or unique as well. And what was remarkable about our group, bearing in mind that we benefited greatly from having a trainee nurse, a trust chief executive, experienced health professionals and managers and representatives of patients and families, was the degree of consensus over the points we're going to make, unanimously felt. The first one was around a need for an absolute revolution in the way that we recruit and train nurses. Like other groups, we felt that there needs to be much more emphasis on the vocational motivation of people coming into the profession, much more emphasis on the caring aspects of nursing, and a rethink on the amount of time that's split between study and academia and the ward, which is currently about 50-50, which we think is completely out of sync, and there should be much more practical experience working with patients, with elderly patients in particular. And on the subject of elderly care, we felt that there was much more focus on the needs of elderly patients that was required, helping people or helping the profession regain the status, if you like, something to be proud of and working on an elderly care ward, not something to be disappointed about or slightly ashamed about. And rather than simply having to spend time doing some of the tasks that healthcare assistants currently do, some of the basic caring tasks, there was a strong feeling that that should be part of the role of a nurse, and we ought to get back to that, and that the fragmentation of roles isn't necessarily helpful. The other big point was, and I don't think this has come up really, was about resourcing. There was an overwhelming feeling that we had to completely reprioritise the status and the importance given to caring for elderly patients in our NHS. It does need more staffing, more resources dedicated to it. But there was also a great sense of realism that if you're going to do that, that means that you might have to make some sacrifices elsewhere. There's a lot of talk about choice at the moment. Round the table, I think there was a strong feeling that some of the frills, some of the add-ons to what we can expect as NHS patients, we might be prepared to sacrifice if we could get the absolute basics of caring for vulnerable patients right. Same goes for some of the more sophisticated, groundbreaking surgery or treatments that might currently be expected. And lastly, we had some pointers as well as to how we could improve the day-to-day experience of caring for elderly people on wards. One was on the resource issue. There would be also benefits. We also felt that there was a need to reduce unnecessary admissions and length of stay, and that if you improve the quality of care, you would reduce the length of stay and be able to get people out of hospital when they should, without unnecessary complications also. We felt that relatives were an untapped resource. By that we didn't mean that they should be required to do the basic tasks on the ward that staff should be doing, but they should be given the opportunity to help, and that their information, their ideas about how their loved one should be cared for should have to be taken into account, and that would help everyone. And a key part of that would be that we should reverse the current system which forces elderly people to fit into the staff's routine and to the system's routine into one where individuals' routines and ways of life are taken account of in planning their care.
That's great. Some lovely stuff in there. Any other comments?
More than a little nervous about making these points because they broaden the debate beyond the responsibility of the NHS, and so therefore I need to start by saying none of this minimises or mitigates the sense of horror or responsibility for the events. I mean, staff or as CQC show more widely in terms of lack of respect and dignity. So I hope that's understood. But when I try and think about the problem of the older, frail person, I think there are some wider troubling questions that we don't yet know the answer to and we need to do some work on. One is, for all our absolute responsibility to solve this in the NHS, it seems to me to be part of a wider problem about our relationship with old, frail people in society. And we should be doing work with colleagues in that area, in the ageing expertise area, to understand this problem. And sometimes that difficulty, I've had it in my own family, about the relationship between the feelings of a family and the feelings of healthcare get played out in very difficult, complex ways to the damage of everyone, not least the patient. So I think that this is absolutely our responsibility, but also part of a broader problem. The second is that the NHS culture values cure. And we give ourselves reward for cure, and we find it hard to deal with those people who we are in the jargon offering palliative care to. I think it's very interesting that 30 or 40 years ago we dealt with a particular part of that around cancer patients who were dying by creating a wonderfully positive palliative care movement. Initially it came from outside the NHS. And again, that's a wonderful thing, but we've almost created a special category of dying. That dying of cancer is something that makes you deserving of a very particular, highly respectful death. And dying in old age of multiple morbidities is almost the reverse. And again, I think it's a very troubling problem about how we maybe learn something from the palliative care movement, but of how you apply that sense to the particular importance of death, not for special diseases, but of the natural end to people's life in old age.
Well, that's a good point to remind us of. Just on the points that you've heard people over here, did you have thoughts about what you should be doing around improving care for older people? Matt, you need to have your say.
I think there's room for looking at things like assistive technology. If you look at the falls amongst older people, certainly in hospital environments, first, is the environment fit for people who are either suffering with a dementia or frail, have long ways to go to find the toilets, etc., bells that aren't put near them, that more assistive technology and investment, if you like, in prevention might be greater.
Some of those things can be done at home in other settings.
And should they be in hospital?
Exactly. You can improve the current system, but is that the right system to be improving?
Professor Brian Edwards, I'd like the elderly to be treated just like the rest of us. I detect a very paternalistic tone in much of the conversations we've been having. If I go in the hospital, it's me who's going in, and I'd like to be in charge. I'd like somebody to explain to me what the diagnosis is, what tests are going to be done. I'd like to know how I'm going to be treated, what tests I'm going to be having. And then I'd like to check myself whether I'm getting the right drugs.
Yeah.
So I'd like to be in charge, working with the professionals who I trust and respect. The elderly need exactly the same thing, but sometimes they need a family member to actually take that position for them. And what you can't do is tell the family member they can't be told because it's confidential. So I'd like to be in charge, and so I guess would many families.
Brian, do you want to just explain to... We were having a good conversation in here about that you contributed to around having a care plan that helps you to be in charge. Do you want to say a bit about that?
Yes, I'd like particularly if I've got a complicated disease, I'd like a copy of the care plan. I'd like doctors and nurses to write in my care plan. I'd like to see when I'm in outpatients, I'd like to ask if I can flick through my case notes. In other words, I'm at the centre of the thing, and the brand image for the NHS is, if you come into the NHS, it's the patient who's really in charge.
Absolutely. Thank you.
Can I just have a word to the younger people? For people over 60 that are elderly, there's an assumption that we're demented, frail and incontinent. We're actually not. Quite a lot of 80-odd-year-olds have been unfortunate to break the hip, are quite able to get on with it. They have the operation and they go home. I do think society actually has a duty to these people. And to be treated as one nurse I heard say, oh, that's the zombie ward, I find quite offensive, actually. If you speak to some of these people that are 80 and 90, you'll find they're bright, they're smart, they're intelligent, they've forgotten most of the things that people half their age will ever learn.
Absolutely.
Okay.
Yes, that's a very good point. Okay.
What we've been hearing over the last few minutes is just reconfirmed to me that actually we just need to treat people as individuals. And one of the things we talked about on our table was you know, the need for just talking to people when they come in to hospital, if they're able to express their opinions, is actually, you know, how would you like us to treat you in a culturally appropriate way? Whether that's because you're young and you want an iPod on, or you're old and you need some special type of care. And the NHS is a massive system, which, you know, we talk about massive sums of money and massive numbers of people involved in it. Somehow the system's become so big that we've forgotten that it's made up of individuals, either professional clinicians and carers and patients. It's just about talking to people about
Absolutely. And I think that
what they want, isn't it?
Lots of people make the same point about treating people as individuals. The reason why we identified the issue of care of older people is that often people have quite complex comorbidities, and it's that sense of the complexity of the case, and sometimes they're physical and mental frailty, not in all cases, but that when people have got all of those things put together, that's when the care can sometimes break down. So that's why we picked up on that particular.
Sometimes young people get put on an older person's ward in an inappropriate way.
So we've gone through our 6 questions, but I did promise you a bit of time at the end for any bits of the last pieces of advice that you'd want to add to the inquiry team that haven't been aired today. Jo, do you want to add something?
Just on a slightly more positive note, also on this one was quite depressing, to be honest, but I think Jim's point about palliative care, there are places where we do get it right in the health service, albeit that tends to be the charitable sector. There's a really good article by a man called Atul Gawande, who's an American surgeon, who says the problem with surgery and healthcare services is that we just focus on the cure. So pain becomes a symptom, it's a clue for disease for the usually male surgeon to track down, and we lose sight of the person, whereas a palliative care consultant, pain is a problem for the patient, it's our job to resolve it. They're the only profession, and it's quite a low status profession in the health service, who actually thinks about the patient, the person, and their experience. So I think there's something we can draw from and learn from that one.
And also that they talk about what the patient would expect and want for that
Absolutely,
time.
all the things we've spoken about is the care plans and what matters to those patients, because they're not, I think in chasing the cure, that's where we lose the care sometimes.
Yes.
My name is Michael Rudolph. I'm from the Patient Involvement Unit at the Royal College of Physicians. We've talked a lot today about complaints, how to generate them, how to deal with them. The one thing I think we haven't emphasised enough is the lack of time in the NHS people are prepared to say the simple word sorry. And I think lots of people want to hear that word. And we seem to have a culture where if you say sorry, you're somehow admitting medico-legal responsibility. And I think we get across to as many colleagues as possible. It doesn't cost anything to say sorry. You're not admitting culpability, but at least you're acknowledging that things went wrong.
Absolutely. Julia, would that have helped you to start a few more stories?
Yes, it would. It would have been nice to have had an apology. But the one thing that once you've been harmed or your relative's been harmed, what you want to know is that that's never ever going to happen again.
Yeah.
Lessons will be learned. And the way the public know that is by, I'll go back to this again, by having complaints published, anonymised complaints, so we can check back 10 years' time, a year's time, if that complaint ever happens again.
Yeah, absolutely. Well, that's true, but you'd also hope that the board was doing that as well. Angela first, and then we'll come back here.
Lord Darcy, I think, did the NHS a great service when he said that quality could be boiled down to 3 important things: clinical effectiveness, patient safety and patient experience. I think we've had quite good leadership from the top, Department of Health and ministers, on clinical effectiveness and patient safety. I don't think we've seen that with patient experience. And if we're going to raise that up to the same level of importance, then we really need to look to more effective top leadership on the issue.
2 out of 3 then so far, is it? Okay, Kieran.
It's just on a related point really. I think that we have to remember that the NHS generally is actually capable of huge things. If you think back to the 18-week target decided there was no way the NHS was going to get a waiting list down. It was just impossible, and it's absolutely managed it. When the system sets its mind to it, as it did politically around waiting times, they made a great improvement, and if they put that same emphasis on these other areas, there's no reason why they can't achieve exactly the same.
But Kieran, I mean, there was a lot of harumphing about having that target, or seal clubbing as Martin called it.
I think if the seal is neglecting my mother and my father, then I want it to be clubbed, actually.
I love these metaphors.
Not quite sure how to follow seal clubbing. I actually want to make a very similar point to Angela, which is quite a general one about patient experience. And firstly, I want to welcome the fact that there is this seminar about patient experience and that is being presented so prominently as part of the inquiry. I think that's brilliant, and it wouldn't have happened 10 years ago. But I think, following on from things like Darcy and putting patient experience as part of quality, there's still some way to go and there's more we need to do. There's kind of arbitrary limits as to where we use patient experience. So we do national measures, but around revalidation of individual clinicians, there's very limited use. We ask for assessments from 30 patients every 5 years. Now, we need to go further if we really want patient experience to be a core part of quality in the future. And that's the kind of one final message from me.
That's a good point. We heard that point yesterday from somebody in the nursing seminar.
Sarah, I think there's a little bit of emperor's clothes as well. We'll have to, or an elephant in the room we haven't talked about, and those resources. The NHS has to meet a set of public expectations, but with limited resources. When I go into John Lewis, I can make the choice whether to spend my money or not. When I have cancer, I don't want to have to make that choice. I want good, fast, effective treatment. But there are limited resources, and we have to engage with the public. We have to have a discussion about what should be done where, and make some of those courageous decisions as well about how are we going to have high quality care given the resources and economic circumstances we have. And we can't duck that issue any longer. Most acute trusts around the country are racking up large deficits, and unless we actually take that elephant and bring it into the room, we're going to be circling it forever.
And some of those things are not unrelated to quality and safety, but patient experience, that doesn't cost a shed load of money to get right, does it?
It doesn't. No, it doesn't, unless of course you have wards which are understaffed, infrastructure which is crumbling because we haven't made decisions about where services can be located, and will attract the right sort of clinical staff who want to work there and have pride in the services they deliver because they have the resources to be able to do the job they're trained to do and want to deliver.
Okay.
Can I just go back to Kieran's point, that I actually didn't want somebody clubbed when they harmed my mum. What I wanted was a cast iron guarantee that it wouldn't happen again. And until there is a change in practice, then lessons have not been learned.
Yeah, so people do want that demonstration of results. It's the motivations people have for complaining.
Just to say, again, I heard something in this room, and it was something I've heard a lot, where people using services talk about care, and we heard somebody say, somebody holding my hand was the biggest thing to me. I'm not sure anything we've talked about will actually get to that, which is back to Mandy's point. What is it patients want, and then work outwards. We complicate this stuff to an amazing degree. One other thing I'll say, the Equality and Human Rights Framework, which was touched upon by this lady from Macmillan, I think it is. We haven't talked much about it, but the NHS Constitution means equality and human rights for every human being. Why don't we raise the level of that document? I know we've talked about it, but then it would have some impact in the system, because frankly, patient voice is not respected.
there's a lot of work gone on to that constitution at the time.
Thanks. I'd echo Joan's point about the NHS constitution. If the system actually did what the constitution said, we'd be a long way further forward in reforming healthcare. I just wanted to make a plug for the inquiry, not just focusing on the lessons learned in the acute sector. Most care is delivered in primary care. We've got a big problem about the quality and the visibility of care in care homes. So I would hope that the inquiry has something to say about lessons learned, about how we can ensure we know that good things are happening in those settings and that we can identify poor practice and deal with it. We know there's a variation of quality issue, a big one, in primary care, but there's much less focus on that than there is in the acute sector.
Thanks. We've talked about staff at a more junior level in the organisation, about their need to have customer care as a focus. But actually there's a responsibility at the top. We've already talked about the boards. And while I'm not into seal clubbing, there is an issue about performance managing senior executive directors for their performance against patients' experience, in the same way as we're seeing happening around finances. You know, there needs to be some way of getting into these organisations at an earlier stage, and if leaders aren't leading with these key priorities at the core of what they're doing, then they need to be encouraged to go and work somewhere else.
Thank you. Very good. Perhaps that should be part of their recruitment assessment process.
Thanks. In years to come, people will be looking at the recommendations from the inquiry and hopefully checking that they're implementing a lot of the recommendations. Things will hopefully have changed. But surely there will need to be a reality check. With all the will in the world, we all agree, I think, that change needs to come from within, leadership, bottom up, etc. But also the kind of reality check and the critical friend role of actually talking to NHS organisations and saying, what are you doing about that? Are you still doing this? That is a great expectation, I believe, of the new Healthwatch organisation. How do we make that real? And I share the concerns expressed earlier on that the current proposals for Healthwatch would not make it fit for purpose. It needs to be much more joined up. There needs to be guaranteed levels of resources consistently across the country, and it needs to be completely independent. If you like, as many people have said during the course of the inquiry, to be much more like what we experienced years ago with community health councils, a local identifiable one-stop shop, or to put it a more modern way, to do the formidable role that Cure the NHS has done, to be a local, trusted, outspoken, vociferous champion of patients and local people. As currently constituted, I don't believe it would be able to do that.
Watch this space, perhaps.
I think that without labouring the point about the bed booking, there are actually systems that we need to look at. We have excellent clinical care, we have expert patients, not the expert patient programme, expert patients who are capable of managing their long-term condition with their physician and reducing costs, reducing readmission to A&E if that process is enabled. The current hospital systems and mechanisms, for example, bed booking and appointment booking don't support the system, and actually to change the system we need to start listening to and empowering patients, and that's my plea today.